Hello everyone, welcome to my channel. So after a long time I am there back on this channel. I was not there, I was not in the mood to make a video. I was in all festival mood and just celebrating the new year. So welcome to my channel. I am Dr. Saurabh Dixit and today we are going to discuss a very important topic. The topic has been there for demand and the topic is going to be the GI bleeds. So when we talk about GI bleed, it's a very simple, easy chapter to understand. I don't know why students panic a lot, but there's a concept that many students get confused in a lot of things. So today I shall just summarize the GI bleed in 15 to 20 minutes. It's a very important chapter from examination perspective, and equally it is important for your exams as a doctor, as a surgeon. So let us try to just overview this topic. So when we talk about GI bleed, the next question is whether it is upper GI bleed or whether it is lower GI bleed. Now who is going to decide whether it is upper GI bleed or whether it is lower GI bleed? Now there has to be a, you can say, a landmark which will decide. Yes, the answer is, you can comment in the comment section below. Yes, it's ligament of Treats, or you can say DJ flexure. So if you have the source of bleeding proximal to the ligament of Treats, it's upper GI bleed. If you have it proximal to the, you can say, ligament of Treats. So when we talk about ligament of Treats, how do we see it? This is proximal. So the source is proximal to the ligament of Treats. Now when we talk about the, you can say, lower GI bleed, the source is distal to the ligament of Treats. So if we take a colonic bleeding, or you can say a jejunal bleed, or a small intestinal bleed, basically except the duodenum, it is what? It's a lower GI bleed. So it's not like if the GI bleed is coming from the, you can say, anus, then only it will be lower GI bleed. It has to be decided on the, you can say, benchmark of the location. So if it is from the source which is proximal, it's an upper GI bleed, else it's a lower GI bleed. Now the frequent terms that we use in context with the GI bleeds, now we have to understand those terms. First is hematemesis. Now when we talk about hematemesis, what do we mean by hematemesis? It's a very simple, straightforward term, that hematemesis means emesis of blood. So whenever there is emesis of blood, try to understand that is what is known as hematemesis, and this hematemesis is always an upper GI bleed. It's always an upper GI bleed. The next concept is, what is the concept of melena? Now what is melena? Let us try to understand this concept of melena. Now most of us know what is melena, despite that fact we don't completely understand the concept of melena. So what is melena? It's a classical terminology for black colored stool? No, it should be tarry. What do you mean by tarry, students? Like a coal tar. So black tarry, foul smelling stool. So black plus tarry, that means that coal tar like consistency, and foul smelling stools, they are actually known as melena. Now we often think that melena is what? A lower GI bleed. Exceptionally in few cases. No, this is not right. This is wrong. Why this melena happens? Now this melena never happens because of the stool. It is because of the blood. And you know, blood contains hemoglobin, and hemoglobin, if you talk about, has hemosiderin. So when you talk about hemoglobin, it has hemosiderin. Now when it is going, or when it travels, so the blood, while it travels into the gut, there's a time when in upper GI, when you talk about upper GI site of origin, there is an interaction of this hemoglobin with the acid, and this hemoglobin is actually converted into, by the peroxidase activity of this, you can say, acid, it is converted into acid hematin, and this acid hematin gives you the typical coffee brown, or you can say reddish black, or a blackish what? That melena like consistency. So one thing is to be there, okay, if acid is there, it has to have a time for interaction and conversion into what? Black tarry stool. And this is only possible in upper GI bleed when you have a long transit time. Try to understand, when you talk about upper GI bleed, you have acid which interacts with the hemoglobin. If you talk about the intestinal source of bleed, like the duodenal bleed, okay, it's fine, because once the acid enters into the duodenum, much of it is neutralized. So the concept of melena starts to decrease, and by the time the acid reaches the duodenal flexure, or you can say DJ flexure or ligament of Treats, most of it is neutralized. So point number one, in lower GI bleeds, or if you take as a source distal to the ligament of Treats, you don't have sufficient amount of acid leftovers. It has been already neutralized by the alkaline atmosphere. And the second is the transit time is short now. So there are two reasons. So long transit time and you can say interaction with the acid, they're the two factors which are responsible. Now the question is, okay, we understand it's mostly upper GI bleed. So we understand that it is mostly upper GI bleed. So can melena be a lower GI bleed? Now there are two big troubles. First of all, acid is not there, but yes, the colonic flora, the intestinal flora has a peroxidase activity. But what you need? A sufficient time. So in case of slow gastric transit, so if there is a slow gastric transit, do you know that even the lower GI bleed, gets sufficient time to interact with what, students? To interact with the colonic bacteria, or you can say colonic flora, to convert it into what, students? Yes, it converts it into a melena. So there are reasons. Ultimately, it is the peroxidase activity that we want to see. Now there's a big, you can say, confusion that in a country like India, you have a patient, or you have a majority of the female patients presenting to you with anemia, and you prescribe iron folic acid. The moment you start with this iron supplementation, most of the patients will turn back to you saying now they have an altered bowel, you can say consistency that looks like a black stool, and this is actually ominous. And sir, I am a bit worried what has happened inside. So does the black stool qualify for this? So merely having the black stool doesn't qualify for melena. Why it doesn't qualify? Because of two different point of views. First of all, this in case of iron supplementation. So it could be in case of iron. So black stool can be in case of iron supplementation, point number one. The second thing is, yeah, sir, it could be melena. So when you talk about iron supplementation versus melena, how you decide? The first thing that you need to understand is the consistency. Now this is what is very, very, very important. So when you talk about the consistency, this is well formed stool. Now this is what is very important, well formed stool. Against melena, if you talk about, when you talk about melena, what is present in melena? They are tarry. So they are tarry, and of course stool are foul smelling. So I'll not, you can say, talk about that point. The second thing that you talk about, when you check for the peroxidase activity. So how do you check this peroxidase activity? Now this is what is very, very, very important. In this case, we go for a test which is known as guaic test. So when you talk about guaic test, this test is positive for the patients in melena because melena has blood. Iron supplementation black stools, they don't have, and this is why the guaic test is negative. So we have come across one term which is melena, and another term, that is the concept of hematomesis. Next is, let us talk about one more concept, that is hematus. We have seen hematomesis. Now let us talk about hematoragia. So there is something which is known as rectoragia. What is difference between rectoragia and hematochezia? There are two terms. So let us talk about first hematochezia. Now what is hematochezia? This is stool admixed with fresh blood. So blood mixed with stool. Now this is very important for you to understand blood mixed with stools, because many of you are actually convinced by the fact that every bleeding PR is hematochezia. No, this is not right, because in case of hemorrhoids, you don't have the blood mixed with the stools. You have only fresh bleeding PR. So fresh drop of blood falling into the pan after or post defecation because of the abrasion of the hemorrhoidal cushions done by the hard impacted stools. So what you have to understand in this case of hematochezia, it is blood mixed with stool. So the classical words are like streaks of, you can say, blood on the stool, or the tissue paper soiled with what you can say stool and blood. Now what is a term that we say or that we comment for the fresh bleeding PR unrelated to, you can say, unrelated to defecation, or you can say unrelated to stools? That is known as rectorrhagia. Now what is rectorrhagia? Rectorrhagia is a classical word for fresh bleeding PR. So when you talk about fresh bleeding PR, when you don't have any stool admixed with the blood, that is what is known as rectorrhagia. So hemorrhoidal bleeds are rectorrhagia. This is what is very, very, very important. The next question is like, melena was upper GI bleed. Could it be lower GI? Yes, we saw, because of a slow gastric transit. In case of slow gastric transit, like in cases of constipation. Now my question is, rectorrhagia or you can say hematochezia, they are lower GI bleed. So can they be? So can it be upper GI bleed? Answer is rarely. Now why rarely? You must be thinking that there is acid also, there are everything, if you don't give time. So in case of rapid gastric transit, so if there is a rapid gastric transit, then the blood doesn't get enough time to get oxidized, and that is why you can get to see this. So this is what is very, very, very important. So both melena can be upper GI as well as lower GI, and vice versa, hematochezia or rectorrhagia can be. Now there are two more terms that you need to understand. They are again very, very, very important. One is obscure bleeding and one is occult bleeding. So most of us know that occult bleeding, there is something which is known as occult bleed. Now what is the concept of occult bleed, students? We all need to understand. Occult bleed means the source of blood or blood loss is there, but there is no evidence of any active blood or bleeding. So suppose if you see a patient of malignancy, suppose any GI malignancy, you will always see one thing as common, that is anemia. Patient is having pallor, patient is having all the symptoms suggestive of anemia. And then you ask patient, did you have any episode of hematemesis? Patient says no. Then you ask patient, did you have any black tarry stools? Patient says no. Any fresh bleeding? No. So what is occult bleeding? The symptoms suggestive of blood loss are present, point number one, but no active clinical episode of bleed. So clinical episode of bleeding. Now this is a place where the bleeding has happened, but it is in such a minuscule quantity that slowly the hemoglobin actually depleted, or it could be the chronic debilitation over the time that you see with a malignancy. So now when you have such a patient, what do you think? A patient presenting to you with dyspepsia, active anemia, lot of things are there, you go for endoscopy. So endoscopy, in these cases the endoscopy is actually what, students? Diagnostic. So if endoscopy has a tendency to diagnose, so suppose if you have a patient of pallor and suppose early satiety, you went with upper GI endoscope and you saw an ulcer in the stomach and you went for a biopsy, that biopsy shows you you can say signs of malignancy. So it's an occult bleed. Now there's one more term, obscure bleed. Many of us actually interchange and use this word obscure versus occult. Now try to understand that two different words. So when you talk about obscure bleed, before we go to obscure bleed, what was occult bleed? Endoscopy detected the thing, but clinical episodes were missing. So here the clinical episode of bleeding is what present? In obscure bleeding, clinical episode of bleeding is present, but the endoscopy generally it may be upper GI endoscopy or lower GI endoscopy. They are usually what, students? They are usually negative. Now you will say, sir, how is it possible? I'll say yes. Conventional upper GI endoscopy, they go up to the second part of the duodenum. At max you may stretch to see third part of duodenum. Similarly, lower GI endoscopy, if you talk about colonoscope, it goes up to the terminal ileum or maybe 10 to 15, 20 centimeter of terminal ileum also. After IC junction they can see. Then what about the complete small intestine? In small intestine, it's very difficult to negotiate the scope. Why? Because the intestine is free. So in a free structure, unless you stabilize the lumen, you cannot, you can say, advance your scope. So complete small GI bleeds, they are actually a mess. So all those small GI bleeds like Meckel's diverticulitis related bleeding, or you can say angiodysplasia, they are all missed off. So what is an example for this? Carcinoids. The classical is carcinoids, and that is intestinal carcinoids. This is what is very small intestinal carcinoids. This is very important. Then we have Meckel's. They are also. So endoscopy in these cases are negative, whereas the clinical episodes are positive. So they are the standard terms that we have to understand. Now let us talk about a basic approach to a patient of upper GI bleed. Now this is what is very common. Upper GI bleed is a huge chapter. So generally for the residents, my master course is actually going to be launched on the GAME app, master course for residents and super specialty students. So for surgery residents, it's a boon. And there I am discussing, I'll be discussing this chapter in great depth for them. But yeah, here as per promise, I want to create an overview. So let us try to understand. If you have any patient of upper GI bleed, suspected upper GI bleed, so how do you assess these patients? How do you work up for these patients? So the first thing is that you do is don't talk anything, don't ask anything. Just try to secure the A, B and C. Why you need to secure A, B and C? A is for airway, B is for breathing, C is for circulation. Now this is what is very important. Airway, breathing and circulation. Now what is the concept of this airway, breathing and circulation part? Let us try to understand. This is what is very important. Because whenever there is upper GI bleeding, the cause of bleed is important, but more important is to secure the airway, because there is risk of regurgitation as well as aspiration. Next is breathing and circulation are the important aspects. So patient might go into hypovolemic shock, so you need to choose the fluid. Crystalloids are the first line fluid, and do send the blood for cross matching and plan it for that. And you need to choose a cannula, you need to choose it wisely. I've already go to my section of fluids, I've discussed it there. And then you do what? Post stabilization start assessment. Now this is where the things will happen. So when you talk about the start assessment, there are 2-3 things that you need to follow. One is the clinical assessment. So clinical assessment, when you talk about clinical assessment, there are 2 important things. History is one very important thing, and there are some scores. There are some scores to assess the severity. I shall discuss about them after this. And then you will always go for Ryle's tube decompression. Now why is Ryle's tube decompression very important? Because if you don't decompress the upper, you can say upper GI tract, there will be again and again regurgitation and further worsening of the scenarios by causing recurrent aspiration. So Ryle's tube decompression helps you reduce the source of bleeding. And then you can say examination of aspirate. So when you do the Ryle's tube decompression, you have a tendency to aspirate and you do an aspirate assessment. Now what is the advantage of doing aspirate assessment? You are going for a bedside assessment. So on aspirate, when you do aspiration and when you examine the aspirate, if you see what is the content, if it is blood, then students, it confirms upper GI bleed. This is what is very important. If it is bile, so you know bile is secreted from the into the duodenum. At second part of duodenum you have ampulla. So if it is bile, that means up to second part of duodenum everything is clear, second, third part. So try to understand that upper GI bleed is actually what, students? Ruled out. And then if you have in content blood plus bile, so blood plus bile, if it is there, then this is an equivocal scenario, then you need endoscopic confirmation. So this is how you do a bedside assessment. Now this is what is very important. Why it is important? Let me tell you, because it gives you a basic idea. Now One more thing that you need to understand, once you do a Ryle's tube decompression, you are decompressing the upper GI tract. Along with that, you will also go for injection PPIs. Now, once you have done the, you can say, basic ABC, you also have to go for IV PPIs. Now, what is the concept of IV PPIs? Now, you will say, sir, every patient is not going to have the peptic perforation related, or you can say GI bleed due to peptic ulcer disease. Point number one, that acid or peptic ulcer disease is the most common cause of upper GI bleed. And what is the role of PPIs? It is not going to decrease the GI bleed, or it is not going to stop. It's not a, you can say, coagulant. Try to understand, it further reduces the incidence of GI bleed. How it does? Because it reduces the acid level, and hence the further damage to the vessels or the capillaries is minimized. So, what is the role of IV PPIs? It is risk of rebleeding. No, this is what is very, very, very important. It decreases the risk of rebleed. Now, this is what is very, very, very important point, and has been asked a lot of times in your exam. So, once you have done all these things, now is the time that post hemodynamic stabilization. So, you have started with Ryle's tube decompression, and now post stabilization. What type of stabilization? Hemodynamic stabilization. You need to check what is the source of bleed, and this is both diagnostic, therapeutic and prognostic. Yes, you are going to go for upper GI endoscopy. Now, this is what is very, very, very important. Why upper GI endoscopy? Because not only it is diagnostic, you have to understand it is also therapeutic, and it is also prognostic in nature. Now, these are very, 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 very important things. Now, further on this upper GI endoscopy, I will discuss as the chapter moves on. Since this is a summary, this is an overview, let me tell you what are the ways you can stop. You can do clipping, you can do injection sclerotherapy, you can go for injection of a vasoconstrictor. We use epinephrine into dilution 1 to 10,000, a lot of things. Or you can use an high-end monopolar coax, bipolar coax, or argon plasma coax. There are a lot of, you can use lasers, ND-YAG lasers, there are a lot of things that you can use. Even holmium can be used nowadays. Let us try to work on with the scores. What are the classical scores? I shall just write the names of them because I use the term scores. So, let us be more watchful on those things. So, when you talk about scores of the GI bleed, what are the classical scores of the GI bleed? We have a score by the name of bleed itself. Bleed. So, what is this bleed score all about? Bleed, let us take it as you can say a mnemonic. So, B stands for blood loss. So, how do you document blood loss? Students, the classical way to see is systolic BP less than 100 mmHg. Yes, it is deciding that okay, the blood is falling on the on the other side. So, we get to see that blood loss, evidence of blood loss is there, and then L stands for low systolic BP. So, one is you have a episode, patient is telling that there is blood loss, and how documented? Low systolic BP. Then E stands for elevated INR. So, whenever there is a coagulation cascade activation, coagulopathy has to be documented for. So, you get to see elevated INR, and how much is significant? Into 1.2 times the normal. Normally, it is 0.9 to 1.4, 1.5. Now, it is going to be on the higher side because there is bleeding. Next is erratic mental status. Erratic mental status is there, and then D is disabilities. So, disabilities or comorbid diseases, they are very, very, very simple things that you need to understand. So, out of them, if 3 or more parameters are positive, let us be very simple. Out of them, if 3 or more parameters are positive, this is first of all indicative of hospital admission. So, this is an admission criteria also. The second is it is associated with poor prognosis also. So, you need to admit the patient, you cannot admit the patient, you cannot keep the patient daycare and discharge, no. So, and it warrants for further evaluation of the cause and hence treat it. So, this is about the bleed classification that we actually see. What are the other classifications that we have or other scores we have? I just write the name for them. Blatchford, you can go to my detailed courses to see them. Then we have Rockel. Rockel is actually the most important parameter, you can say score. Rockel, there is one score, Rockel. And then there is one more score specifically, or that's a classification for the peptic ulcer disease related bleedings. And what is that? Yes, you must be guessing right. You can comment in the comment section below. That's a Forest classification of Forest is very important. Forest classification of what is Forest classification? Actually, it's a classification for GI bleeds related to peptic ulcer disease, and it's not only a classification, it's a prognostic index to decide whether or no what is the risk of rebleed. So if you talk about what Forest grading we talk about, so on one side I will discuss this because this is of paramount importance. So on one side grade, on another side we have the remark, on the other side we have risk of rebleed. Now there are three things that we need to understand: grade, remark and risk of rebleed. Now when we talk about grade 1, so 1 we have 1A and 1B. So when we talk about 1A, this is active pulsatile bleed. So active pulsatile bleed. Now this is what is very important. So what do you mean by active pulsatile bleed? So pulsatile means it's an arterial blood, and that is why the risk of rebleed has to be what? High. Now what is 1B? So it is also active bleed. So active non-pulsatile bleed. So active pulsatile we have and active non-pulsatile bleed. When you talk about active non-pulsatile, what does it mean? It means oozing, and this is actually a typical you can say orientation of a venous bleed. So what will be the risk of rebleed? Again students, if it's a vascular bleed which has already occurred, the risk of bleed has to be high. Then we have the grade 2. Now grade 2 is a non-bleeding state. So non-bleeding, so this is 2A. So non-bleeding visible vessel. So non-bleeding visible vessel, what does that mean? There is a mucosal submucosal atrophy, and now the vessel is visible but it is not bleeding. So you know the barrier has already been lost. The acid in no point of time will erode or denude this, you can say, superficial adventitia over the vessel, and it will cause it to rupture. So if there is any context with active blood bleeding, or if the blood vessel is visible, it has to be a high risk of rebleed. When you talk about 2B, it's an adherent clot. Now what do you mean by adherent clot? Now there was an episode of bleeding, so this is a stigmata which the bleeding has left over. Now clot is, you can say, a fibrin product, so it has two fates. Either it can get dislodged and rebleed can occur, or it can get fibrosed well and it can epithelize over. So remember, the risk of rebleeding is intermediate, and to your surprise you should understand that majority of the time, next time when you see upper GI endoscopy for bleeding patients for peptic ulcer, 90% of them are in 2B. Why? The patients have been hemodynamically stabilized, then only sent for this investigation. So most of the time the patient is in 2B. Now what is 2C? What is 2C? It is, you can say, shallow pigmented ulcer base. So when you talk about shallow pigmented ulcer base, now this ulcer is now on the track of getting epithelialized and fibrosed. So pigmentation is an evidence that yes, hemosiderin was there, and hemosiderin, that means hemoglobin. So yes, the risk of rebleed is now going to be low because now it is on the track of fibrosis. The next and the last is 3. What do you mean by 3, students? It's a very simple thing. 3 means a healed ulcer. So whenever you have a healed ulcer, this is classically a 3, and the risk of rebleed is actually going to be low. So now this is a very composite overview I have discussed. Now without wasting a lot of time of yours, I'll just discuss the causes, because if I go into the depth of causes it would be very long. So wait for my course which is getting launched in March, and I'm coming up for the surgery residents and super specialty students on Global Academy of Medical Education. So for them it will be a detailed discussion on lot of things. So let us try to see the causes of upper GI bleed. So when you talk about the causes of upper GI bleed, what are they? So you need to understand that there are two broad categories. Now what are these two broad categories, students? It could be non-variceal causes versus variceal causes. So there are variceal causes of bleeding versus non-variceal. Yeah. So when you talk about non-variceal versus variceal, less than 20% of them are variceal, more than 80% of them are non-variceal. Now when you talk about non-variceal causes, what are the classical? You can have the portal hypertensive state causing a lot of things. So gastroesophageal varices, point number 1. So gastroesophageal varices, point number 2. It is isolated gastric varices. I hope you must have heard of this. An isolated gastric varices is of two type, IgB1, which is exclusively the varices seen at the level of fundus. If it is present anywhere except the fundus, it's IgB2, and you get that typical cherry red spots on upper GI endoscopy. More on that in the detailed course. The third that you have to understand is the portal hypertensive gastropathy. Portal hypertensive, you must have heard that proximal part of the stomach, you have the typical snake appearance. Yeah. So portal hypertensive gastropathy. The classical DD of this portal hypertensive gastropathy is your is your classical GAVE, gastric antral vascular ectasia. The difference is GAVE is in antrum, that is in the proximal stomach. GAVE never respond to beta blockers, they respond dramatically. GAVE you get to see that watermelon pulp like appearance, here you get to see the typical snake skin appearance. So there are a lot of things that you need to understand about them. GAVE is associated with mucosal hyalinization, they are not. Let us come back to the non-variceal causes of the bleeding, which let us see. So the most common cause that we have is the peptic ulcer disease. So you have to understand that peptic ulcer disease is the most common cause for this, point number 1. The second we have to understand it is gastritis. So they are in order. Gastritis. Okay. Before that, this is not the second, this is the third. So second goes to Mallory Weisstiers. So it's my bad, I take it back. So second goes to Mallory Weisstiers. So Mallory Weisstiers, it's a you can say classical mucosal and submucosal laceration. It's not a complete perforation tear leading to the damage to occasionally a branch of left gastric artery or vein. It's artery majority of the time, and that is why you get to see a torrential bleed. The classical thing is upper GI bleed classically following the episode of vomiting. So this is what is very important, because many of the times the classical history is same. Young male with bouts of alcohol, you think there's a patient with young male with bouts of alcohol suddenly presenting to you with hematomesis, you make an answer Mallory Weiss. No, there is no episode of hematomesis, there is no episode of vomiting, so it's a peptic ulcer more frequent diagnosis, because hematomesis, whenever there is a forceful vomiting, there is a sudden clinch of the clasp fibers around the cardia, and that is why there's a tear. That is the difference. So second is Mallory Weiss, third is gastritis, then we have esophagitis, and then you have a lot in the list, like you have Deulefoys, you have a Deulefoizlation. Let me tell you, Deulefoizlation, it's a congenital disorder, and Deulefoizlation, what else do you get to? The classical things that you get to see in Deulefoizlation is there is the antrum is spared, the cardia is involved. So Deulefoizlation, what else do we get to see is we have GAVE, gastric antral vascular ectasia. I've already told you that classical watermelon stomach. Then you have two more things. Let me show you an image of watermelon stomach. This is classical how a watermelon stomach looks like. Can you see classical watermelon pulp, and what is the technology that you are seeing next to it? It's an APC. What is APC, students? APC is argon plasma. So this is argon plasma technology that you get to see, argon plasma coagulation, and this is the standard of the management, and this is classical watermelon stomach. So watermelon, you see, if you see the pulp of watermelon, when you cut it, you get to see a classical watermelon stomach. So there are a lot of things. Then there is one more cause that is known as autoenteric fistula. How do you get to see autoenteric fistula? This is post aneurysmal repair. Whenever there is you can say infection along the aneurysm's repair site, so anastomotic side is weakened, because of the infection, the blood leaks out, resulting in pseudoaneurysm, and since majority of the time it is the infrarenal aneurysm, it is in close connection with the third path of duodenum. The infected area actually infects the duodenum also, and there is erosion because of this mesh. So you can see a classical Dicron mesh popping up in the, you can say, lumen of the bowel. How is it possible? It is the eroded wall of the duodenum as well as the aneurysm side, and that is what is classical view of aortoenteric fistula. So patient with aortic aneurysm repair, massive GI bleed, answer is aorto, you can say, enteric fistula. So you have aortoenteric fistula. There is one more classical thing that you should know, that it can be idiopathic. There is one more thing that you need to understand, that is Haemosuccus pancreaticus. Now what is Haemosuccus pancreaticus? It is nothing, as you read the word Haemosuccus, succus means the juice, blood in the juice of the pancreas. So how is this possible? Chronic pancreatitis associated with pseudocyst. Pseudocyst contains the pancreatic juice. It has a tendency to erode and rupture. If it ruptures into the peripancreatic vessel, most of the time it is a splenic vein. So the blood from the splenic vein enters the pseudocyst into the pancreatic duct and then into the bowel. So since the origin is proximal to the ligament of Treats, it has to be a upper GI bleed. So this is Haemosuccus pancreaticus, and then we have hemobilia. Hemobilia can be seen due to rupture of any pseudoaneurysm of the hepatic artery or nearby vessel, or it could be trauma, it could be ERCP, which is the commonest cause. It is not biopsy because we often don't do liver biopsies, it is ERCP. So whenever you do sphincterotomy, you are cutting a live structure, so bleeding comes out mixed with the bile. The most common cause of hemobilia is classical your ERCP. So do subscribe to my channel. I hope you like this video. This is a small, concise. I could have extended it, but you know, it's beyond the control in you can say social media. Many students don't like a long video, so I tried to concise this for your exam. Do comment in the comment section whether you like the video or no. If you want any topic to be revised, to be covered, to be concised of, you do comment, and I will be more than overwhelmed to teach it to you. So do like, subscribe, press the bell icon, do share my channel links, or do share the links of my videos amongst your friends and near and dear ones, so that everyone actually get to learn a small topic and learn the concepts in fun. So thank you for watching my video. Thank you.